Introduction. Heart failure is a condition in which the heart cannot pump enough blood to deliver the oxygen and nutrients the body's organs need, or cannot fill properly between contractions. Heart failure does not mean that the heart has stopped. It means that the heart is pumping or filling less effectively than it should. The problem is inadequate circulation, not necessarily too little blood, low blood pressure, or low oxygen saturation alone. What happens in heart failure? When the heart pumps less effectively, cardiac output decreases. The body responds by activating the sympathetic nervous system, which increases the heart rate and constricts blood vessels to maintain blood pressure. Reduced blood flow to the kidneys also activates the renin-angiotensin-aldosterone system, causing the kidneys to retain sodium and water. These responses help temporarily, but eventually increase fluid buildup and make the heart work harder. Left-sided heart failure. In left-sided heart failure, the left ventricle cannot effectively pump blood into the body. Blood backs up into the lungs, causing pulmonary congestion. Common findings include shortness of breath, crackles, coughing, low oxygen saturation, difficulty breathing while lying flat, and waking at night gasping for air. Right-sided heart failure. In right-sided heart failure, the right ventricle cannot pump blood effectively toward the lungs. As blood remains in the right ventricle, pressure rises and makes it harder for blood from the right atrium to move forward. This pressure then backs up into the superior and inferior vena cava and into the systemic veins throughout the body. Increased venous pressure pushes fluid out of the blood vessels and into surrounding tissues. As a result, the patient may develop swelling of the feet, ankles, and legs, jugular venous distension, abdominal swelling, ascites, and enlargement of the liver. The kidneys may also retain sodium and water, causing rapid weight gain. The key difference is that left-sided heart failure causes fluid buildup mainly in the lungs, while right-sided heart failure causes fluid buildup mainly in the body. Systolic, diastolic, and acute decompensated heart failure. In systolic heart failure, the ventricle is weak and cannot contract strongly enough, so less blood is pumped out and the ejection fraction is reduced. In diastolic heart failure, the ventricle is stiff and cannot relax or fill properly, even though the ejection fraction remains preserved. Acute decompensated heart failure is a sudden worsening of symptoms, often caused by fluid overload, infection, arrhythmias, uncontrolled blood pressure, or missed medications. Common causes. Heart failure can develop when structural or functional changes weaken the heart or make it work harder over time. Common causes include coronary artery disease, a previous heart attack, long-standing high blood pressure, diabetes, cardiomyopathy, heart valve disease, abnormal heart rhythms, congenital heart disease, and kidney disease. Other contributing conditions include anemia, thyroid disorders, thiamine deficiency, and pregnancy. Common symptoms. Common symptoms of heart failure include shortness of breath, fatigue, weakness, reduced activity tolerance, coughing, and rapid weight gain from fluid retention. Left-sided heart failure commonly causes pulmonary congestion, crackles, low oxygen levels, difficulty breathing when lying flat, and waking at night gasping for air. Right-sided heart failure commonly causes swelling of the legs and ankles, jugular venous distension, abdominal swelling, ascites, and an enlarged liver. Patients may also develop a fast heart rate, decreased daytime urine output, and increased urination at night. New or rapidly worsening symptoms should be reported promptly. To diagnose heart failure, healthcare providers combine clinical findings with laboratory and diagnostic studies. The Framingham criteria support the diagnosis when a patient has either two major criteria or one major and two minor criteria. Major findings include pulmonary edema, cardiomegaly, neck vein distension, orthopnea, crackles, and an S3 heart sound. Minor findings include ankle edema, exertional dyspnea, hepatomegaly, nocturnal cough, pleural effusion, and tachycardia. The New York Heart Association classification grades heart failure from Class 1, with no activity limitation, to Class 4, when symptoms are present even at rest. Blood tests evaluate kidney and liver function, electrolytes, anemia, and cardiac injury. BNP or NT-proBNP levels help determine whether shortness of breath is related to cardiac stress and may also help assess severity and response to treatment. An echocardiogram is especially important because it evaluates heart structure, valve function, ventricular filling, and ejection fraction. A chest X-ray may reveal an enlarged heart, pulmonary congestion, or pleural fluid. An ECG, stress test, and cardiac catheterization may help identify the underlying cause, such as an arrhythmia, coronary artery disease, or an acute heart attack. Heart failure medications narration. Many different medications are used to treat heart failure. Each medication works in a different way, but together they can reduce symptoms, improve quality of life, slow the progression of heart failure, reduce hospitalizations, and help patients live longer. Heart failure medications are usually not used alone. Most patients require a combination of medications because heart failure affects several body systems, including the heart, blood vessels, kidneys, fluid balance, blood pressure, and heart rate. The main goals of medication therapy are to remove excess fluid, reduce the heart's workload, improve the heart's pumping ability, protect the heart from harmful hormonal responses, and prevent the condition from becoming worse. Diuretics, such as furosemide, help the kidneys remove excess sodium and water from the body. This decreases swelling and pulmonary congestion and can make breathing easier. The nurse should monitor daily weight, intake and output, blood pressure, kidney function, and electrolyte levels, especially potassium. ACE inhibitors, such as lisinopril, enalapril, and captopril, relax blood vessels and lower blood pressure. This reduces resistance against which the heart must pump and decreases the heart's workload. Angiotensin receptor blockers, or ARBs, such as losartan, valsartan, and candesartan, also relax blood vessels and reduce the effects of the renin-angiotensin-aldosterone system. They may be used when a patient cannot tolerate an ACE inhibitor. An angiotensin receptor neprilysin inhibitor, or ARNI, combines sacubitril with valsartan. This medication blocks harmful hormonal effects while increasing beneficial substances that help relax blood vessels and remove sodium and water. Evidence-based beta blockers, such as metoprolol, carvedilol, and bisoprolol, slow the heart rate and reduce the heart's workload. Over time, they can improve heart function and survival. Beta blockers should not be stopped suddenly because abrupt withdrawal can worsen the patient's condition. Aldosterone antagonists, such as spironolactone and eplerenone, block the effects of aldosterone. This helps reduce sodium and water retention while protecting the heart from further remodeling. The nurse should monitor kidney function and potassium because these medications can cause hyperkalemia. SGLT2 inhibitors, such as empagliflozin and dapagliflozin, help the kidneys remove glucose, sodium, and fluid. These medications may reduce heart failure hospitalizations and cardiovascular mortality. Hydralazine combined with isosorbide dinitrate relaxes blood vessels. Hydralazine reduces resistance in the arteries, while isosorbide dinitrate decreases the amount of blood returning to the heart. Together, they reduce the workload placed on the heart. Digoxin may be prescribed for selected patients. It increases the strength of heart contractions and can help control the heart rate, especially when heart failure occurs with atrial fibrillation. The nurse should monitor for digoxin toxicity, including nausea, vomiting, loss of appetite, visual changes, confusion, and abnormal heart rhythms. Patients should take heart failure medications exactly as prescribed and should not stop them without speaking with their healthcare provider. They should report dizziness, fainting, severe weakness, worsening shortness of breath, increasing swelling, rapid weight gain, or an unusually slow or fast heart rate. Because these medications can affect blood pressure, kidney function, and electrolyte balance, regular monitoring is essential. Daily weight is especially important because it is one of the most sensitive indicators of fluid retention. The most important point is that heart failure medications perform different jobs, but they work toward the same goal: reducing symptoms, protecting the heart, preventing hospitalization, improving quality of life, and helping the patient live longer. The nurse's priority is to recognize worsening heart failure early and respond before the patient develops severe respiratory distress. Assess the patient's breathing, oxygen saturation, lung sounds, heart rhythm, blood pressure, edema, mental status, and urine output. Monitor intake and output, obtain daily weights, administer prescribed medications, and evaluate the patient's response to treatment. If the patient has severe shortness of breath, place them in high Fowler's position to improve lung expansion and reduce the work of breathing. A sudden worsening of heart failure can cause acute pulmonary edema. Warning signs include severe shortness of breath, crackles, low oxygen saturation, anxiety, and pink frothy sputum. This is a medical emergency. Keep the patient upright, assess the airway and breathing, provide oxygen as prescribed, notify the healthcare provider or rapid response team, and prepare to administer 4 diuretics and additional respiratory support. Daily weight is one of the best ways to detect fluid retention early. The patient should weigh every morning after urinating, before breakfast, using the same scale and similar clothing. A rapid increase in weight may indicate worsening fluid retention and should be reported according to the healthcare provider's instructions. The key message is simple: assess carefully, act quickly, and monitor daily changes before heart failure becomes an emergency.